Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So we are at the last Tuesday of October, but I'm not going to be doing a Top 10 Tuesday today. I'm actually going to save it for November because there's a topic I wanted to touch on today. And I know a lot of us are doing month end. I know I'm really busy. So I wanted to get the episode out, but I wanted to touch on a topic I haven't talked about in a while. But I'm starting to get a flood of emails from my Coding Corner membership clients that are saying that they're not getting paid for transitional care management. So if you don't know what that is a care management code in the CPT book that allows for patients who have difficulty or anticipated difficulty, I should say, transitioning from the hospital inpatient stay, possibly outpatient stay. But basically, they're in the hospital and they need to go to what they call their domicile, and which could be skilled nursing, could be home, could be going to live with a family member. Either way, they need help, and they need someone to help them transition, as the word says, into that area where they need, home health services, or they need prescriptions, and they need just somebody to just be there to really just help them navigate through what can help them to function once they get out of a controlled setting. Remember, when you're in the hospital, they wake you up. Well, for those of you that have never been in the hospital, you should know this. They wake you up for your medications. They wake you up to eat. They wake you up to take blood. They're constantly on top of you to check everything you need, and you have a little button if you need them. And so the codes, CPT codes 99495 and 99496, these are used to report transitional care management services. And what they are is these are services for a new or established patient whose medical and or psychosocial problems, that's important, require a moderate or high level of medical decision-making during that transition in care from that inpatient setting. And again, the inpatient includes acute hospital, rehab hospital, long-term acute care hospital, could be partial hospital, observation status in the hospital, again, nursing facility, but they're going into, and they talk about it, their community setting, which could be home, rest home, assisted living, private residence, short-term accommodations. But what's important for this is some patients also go to a group home. That's tough. And they don't actually have somebody there to help them with this. And so when we talk about this, we're talking about understanding their aspects of care. Do they need home health? Do they need any kind of self-management with support of activities of daily living? Do they need occupational therapy? Medicine management? Do they need, their prescriptions picked up once they leave the hospital? Do they need community resources such as Meals on Wheels or something like that? And what this does is that you are promising, if you're going to take on this code, that you not only understand the patient's clinical profile and what they need, but you're going to help facilitate access to care and these services needed by the patient and possibly the family. And there's other certain non-face-to-face services that the provider may provide, and that could be reviewing some follow-ups for pending diagnostic testing, some other kinds of interactive specifics that the patients need, again, community services, maybe some education on things, establishing referrals. Are they coming out of the hospital where they need an orthopedic referral for a hip, or do they need a primary care referral for noted hypertension in the hospital that maybe they don't have, and assistance in scheduling any of these follow-up services, follow-up with providers. So you're actually taking on a lot. I see this reported incorrectly a lot because these services not only need coordination of care, but you also have to have the physician involved in the initial access of the services. So, the medical decision making has to be a physician or a QHP. And so and they're also time-based codes. And so you have, first of all, the 99495, you have to have communication or direct contact, telephone, electronic, with the patient or caregiver within 2 business days of discharge. And it has to be well documented. And I see that missed a lot. Well, we tried to call. No, that's not enough. You have to have at least a moderate level of medical decision making for that code. And a face-to-face visit within 14 calendar days of discharge that is not separately billable. So that's included in that code, and a lot of people try to bill it extra. No. If you use the 99496 code, that is the same information except the high-level medical decision-making, and they have to be seen within 7 calendar days of discharge. And again, you have to make sure that you're seeing them face-to-face and not reporting that. So I misspoke as far as a time-based code. No, it's a frequency code. So it starts on the day of discharge and continues for the next 29 days. So this is a 30-day from discharge code. So everything you do within that 30 days, and you have to meet the definition of the code because that is, required for this visit. And the discharge service may not constitute, and it even says it on page 50 of the CPT, 60 of the page CPT book, it says that the discharge service may not constitute the required face-to-face visit of this patient, what they need for these services. So where are the denials coming in? And that's kind of what I wanted to address. So these are worth anywhere from $250 to, I said, $325 as far as reimbursement, which you would think is pretty good until somebody says, wait, it includes to bill for an office visit? And it's like, yeah. And they're like, well, for our office visits, we're getting a little more than that. So you have to think about that as well. But here's a question I got recently from one of my Texas Coding Corner clients. It says, we have a denial B15 for a TCM that we billed for a patient. They want previous visits billed for this patient. None of our providers saw the patient in the hospital during their stay. Would we still be able to bill the TCM? 99496 is what we billed, so that's the highest level service, despite not having any hospital records of our doctor seeing the patient while in the hospital. Would we be able to have the discharging doctor send their hospital records to get the insurance to pay for what we did? So the answer is no. You can have that in the record because you probably need it, but somebody else's service to reflect that you have a clinical profile on the patient is probably not going to fly with an insurance company. You heard the information or the qualifying information that you need to be able to bill for this service. And what I'm finding when I see denials here, and it's tough because it's not really in the CPT that you can't do this, but then when you think about the code and the spirit of the code, I can see why these denials would come in. So if you're transitioning a patient from an inpatient perspective, let's say, and to me, that's really where this heads. I mean, you could say, outpatient or something, but outpatient, patients who come in for a 24-hour period or less, I don't really see them using this. But if you have a patient that's inpatient and maybe they don't have family at home, or they do have some limitations in a psychosocial situation or, mental health situation, or they just don't have a way to get their prescriptions or get their home health schedule. They just don't have a helper, really. Then this is where this code is for. But if you're trying to bill for this and you've never seen the patient, how can you justify the medical necessity of the service if you really aren't up or to speed on everything that they need? Because it says all aspects of their follow-up care. And the one thing I also find is there's some providers and physicians out there that are trying to build a practice. So they go into the hospital and they print these lists of discharged patients and then try to pick them up for all this transitional care because somebody out there, and I'm air quoting, told them, hey, guess how you can make some money? And that's just not okay. So if you don't know the patient, or if you have not been involved with their care in any aspect of their hospital stay, I would shy away from these codes because you're going to get a denial and you can't go then and bill the patient. And so you have to have some hospital records. You have to have some insight more than just reading a discharge summary saying, I know who this patient is. I've been involved in their care. That's why I'm here to help them transition into their community. The other thing is make sure let's say you do qualify, okay, you are the qualifying provider, you want to bill these services, which I think it's a great service, but to me, it's not a money-making service. It's a great service for the patient. Maybe it'll help you with your MIPS. It probably will break even, but to me, it's definitely not a moneymaker. But it is a great service because a lot of patients need this. But let's say you do qualify, but you didn't do the reciprocal, 48-hour call and you didn't get a hold of anybody. Or let's say you didn't have the face-to-face in the required time frame. There's still timeline issues here, the 7 to 14 day face-to-face, the 48-hour call. And it can't be clinical staff only. It has to be for those initial services. The face-to-face has to be a physician or qualified healthcare professional, so nurse practitioner, PA, and the phone call also has to come from those people. Because remember, the patient has to be able to ask questions about their health, and a medical decision has to be able to be an option for that patient over the phone in those first 48 hours. And so if they're, feeling like I'm still feeling lightheaded from the hospital, or I'm still nauseated, or I just feel like this medication isn't working, or something there. Usually the worst part for a patient is when they first get out of the hospital, the unknown, because again, people aren't used to, once they get out of the hospital, having to fend for themselves, because the hospital is so staff reliant for the patient. I mean, that's why some patients need to be in the hospital, because it's just such a good thing for them. And so if they don't have that first 48 hours of somebody reaching out that has clinical knowledge of who they are and can answer those questions. That's not a medical assistant. That's not even an RN. And so you have to make sure that those are the types of providers you have available. You have to reconcile their medications. That's a really big part of that code. Now, Medicare actually puts that one out. And so those are the types of things you have to keep in mind. Now, the clinical staff or the other staff that help from the team that is allowed, that's who schedules the, home health or the OT, or, make sure that the prescriptions are picked up and follows through with that. Administrative duties, those kinds of things. So know what you're getting when you're billing these codes, know what you're telling the payer when you submit these codes, and make sure you have some kind of compliance model. Something that actually reflects the things I just talked about here. So everyone knows, if you're going to bill this is what you have to make sure that is in the documentation, is absolutely being supported and it's being performed. Otherwise, you could be billing for a service that you did not support, or you're going to get denials, and patients are not going to be happy with that. Okay, and a personal tidbit. So somebody asked me, hey, what are you reading lately? Well, if it's not something that's work, I just got my new 2025 CPT book. So I was like, oh, yay, Christmas came early. What am I reading? Well, as most of you know, I just got back from vacation from Hawaii, and I started a book called The Senator's Wife, and it's pretty good. So it's on my Kindle, and so if anybody wants to read it, it's a really good book. But I'm going to tell you, it's kind of it's politics, it's affairs, it's basically a trashy novel. I'm just going to put it out there, but it hits you in the face right when you read it. So if you need a break from work, it's actually a pretty good book to read. And actually, it's not as trashy as like Jackie Collins back in the day. That was pretty graphic. It's not like that. It's intrigue. It's again, it's politics, and I know a lot of you have had enough of politics, but it's not like what we have out there, in real time. It's more what you expect from a novel. So it's pretty good. Even my daughter's reading it, and she's like, "Oh my gosh, this is crazy." I'm like, "I know." So anyway, if anybody's interested in that, make sure you look at that. And lastly, my Steelers are 5-2, so I'm excited to see what they do this weekend. We're on. You're actually getting this before the game played for me, so I'm recording this on a Saturday. But Monday Night Football, so you'll know that by the time you hear this podcast, will I be mad on that Tuesday, or will I be happy going into the week and Halloween? So everyone here, also happy Halloween. If you have kids or grandkids or anything, that's their favorite time and they just love it. And I like it too. I think it's pretty fun. So hopefully everyone has a great week. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.